Bismillah ar-Rahman ar-Rahim. Today we will talk about thalassemia. It is the most common genetic disorder on worldwide basis. Children with thalassemia have shorter RBC life, more hemoglobin F, and the RBCs are more sensitive to the oxidative stress. Epidemiology. There are more than 200 mutations for beta thalassemia. Most of them are rare. About 20 mutations represent 80% of the total. About 3% of the world's population carry genes for beta thalassemia. About 5 to 10% of the population of Southeast Asia carry genes for alpha thalassemia. Normally, there are 2 beta globin genes and 4 alpha globin genes, which leads to tetrameric globin protein, which combines with heme, leading to hemoglobin formation. Pathophysiology of thalassemia. Hemoglobin is a tetramer consisting of 2 pairs of globin chains. Abnormalities in this protein are referred to as hemoglobinopathies. There are approximately 800 variants hemoglobin. After 8 weeks of fetal life, the embryonic hemoglobin are found, which are GAWR1 combined of zeta 2 epsilon 2, GAWR2 alpha 2 epsilon 2, and Portland zeta 2 gamma 2. At 9 weeks of fetal life, the major hemoglobin, which is hemoglobin F, which is alpha 2 gamma 2, is formed. At approximately 1 month of fetal life, hemoglobin A, which is alpha 2 beta 2, appears, but does not become the dominant hemoglobin until after birth. When hemoglobin F levels start to decline, a minor hemoglobin, which is called hemoglobin A2 alpha 2 delta 2, appears shortly after birth and remains at low level after birth. The final hemoglobin distribution pattern that occurs in childhood is not achieved until at least 6 months of age and sometimes later. The normal hemoglobin patterns is more than 95% is hemoglobin A, less than or equal to 3.5% hemoglobin A2, and less than 2.5% is hemoglobin F. In beta thalassemia, there is an excess of the alpha globin chains relative to the beta globin chains and gamma globin chains, which lead to alpha globin tetrameric inclusion called alpha 4, which interact with RBC membranes and decrease RBC survival, leading to anemia and increased erythroid production. There are normal levels of gamma globin and delta globin chains production, which lead to increased hemoglobin F and increased hemoglobin A2, respectively. In alpha thalassemia, there is an excess of the beta globin and gamma globin chains relative to alpha globin chains, which lead to formation of Bart's hemoglobin, gamma 4, and in fetal life, and hemoglobin H, beta 4 after birth, which lead to extravascular hemolysis. In bone marrow, the thalassemic mutation disrupts the maturation of the RBC, which lead to ineffective erythropoiesis. That's to say, the marrow is hyperactive, but there are relatively few reticulocytes associated with severe anemia. Now we'll talk about the most common type of anemia, which is homozygous beta thalassemia or thalassemia major, or what we call Cooley's anemia. Clinical presentation: patient usually become symptomatic during the second 6 months of life if untreated due to progressive hemolytic anemia with profound weakness and cardiac decompensation. Hemoglobin is about 1 to 60 grams per deciliter. Blood transfusions depends on the ability of the child to compensate for the degree of anemia, usually from 2 months to 2 years of life. Severe anemia can lead to fatigue, poor appetite, and lethargy. The classic presentation of the severe thalassemic facies as frontal bossing, mandibular malocclusion, and prominent malar eminence due to extramedullary hematopoiesis, pathologic fractures, marked hepatosplenomegaly, and cachexia is still seen in some developing countries. The spleen may become so enlarged, which lead to mechanical discomfort and secondary hypersplenism. Pellar hemosiderosis and jaundice may lead to the greenish-brownish complexion of the patient killer. Transfusion therapy lead to decreased severity of this feature and increase what we call transfusional hemosiderosis due to iron overload, especially in developed countries. Iron overload can lead to liver fibrosis and cirrhosis, diabetes mellitus in pancreas, growth retardation and hypogonadic hypogonadism, hypocalcemia and osteoporosis, arrhythmia, myocarditis, and intractable heart failure. Laboratory findings in thalassemia include in hemoglobin electrophoresis there are absence or decreased hemoglobin A relative to hemoglobin F. Infants usually born with only hemoglobin F. With time there will be severe anemia, few reticulocytes, numerous nucleated RBC, and microcytosis with almost no normal appearing RBC on the smear. The unconjugated serum bilirubin is usually elevated. Even if without transfusion there will be iron accumulation, that is increased serum ferritin and increased serum transferrin saturation. Bone marrow hyperplasia can be seen in radiograph. What about treatment of thalassemia? Regular blood transfusion is the mainstay of treatment with a post-transfusion hemoglobin level of 9.5 gram per deciliter is the goal of our treatment. Excessive iron store from transfusion can cause many of the complications of beta thalassemia major. Accurate assessment of excessive iron store is essential to optimal therapy. The serum ferritin is useful in assessing iron balance trends, but does not accurately predict quantitative iron stores. Quantitative iron by liver biopsy is the standard method for accurately determining iron store for patient. T2 MRI software is now being used to estimate iron store in the liver and heart among patients with beta thalassemia major. Excessive iron stores can be prevented by use of deferoxamine, Disferal, or Deferazerox, which is XJ. Chelation therapy by Disferoxamine is given subcutaneously over 10 to 12 hours per day, 5 to 6 days per week. Side effects include ototoxicity, retinal changes, bone dysplasia with truncal shortening. The oral iron chelator Deferazerox, which is XJ, is commonly available in USA for many patients and families. Deferazerox has replaced deferoxamine. Although the optimal dose of Deferazerox is well defined, some patients have a less than expected response to the maximum approved dose, which is 30 mg per kg per day. Splenectomy, another option, may be indicated for patients with thalassemia intermediate and falling steady state of hemoglobin, increase in transfusion requirements. Side effect of splenectomy, there may be serious infection, so all patients should be fully immunized against encapsulated bacteria before splenectomy, and they should be on long-term penicillin prophylaxis after that. Bone marrow transplantation may be successful for some patients. Most patients less than 15 years of age without iron overload, without hepatomegaly, and who have HLA matched spleen. Bone marrow transplanting is the single best treatment for thalassemia, but with some indications. Other type of beta thalassemia include thalassemia intermedia, presented as microcytic anemia, hemoglobin more than 7 grams per deciliter, growth failure, hepatosplenomegaly, hyperbilirubinemia, thalassemic facies, which is usually developed at 2 to 5 years of age. Thalassemia minima and minor, when there is more severe than thalassemia trait but less severe than thalassemia intermedia, and thalassemia trait, which is presented as minimal or no anemia, hemoglobin is about 9 to 12 milligram per deciliter, microcytosis and increased RBC count, hemoglobin electrophoresis may reveal an increased hemoglobin F and increased hemoglobin A2. The last subject is alpha thalassemia. It is most commonly found in Southeast Asia. Infants are identified in the newborn period by an increased production of Bart's hemoglobin, which is gamma 4, during the fetal life and its presence at birth. Alpha thalassemia differs from beta thalassemia. It can be presented at birth. There are 4 alpha globin genes and 4 deletional thalassemia phenotype as follows. First, deletion of 1 alpha globin gene lead to silent carrier with normal appearance. Second, deletion of 2 alpha globin genes lead to alpha thalassemia trait with mild microcytic anemia. Third, deletion of 3 alpha globin genes lead to hemoglobin H disease with moderate microcytic anemia, splenomegaly, and jaundice. Fourth, deletion of 4 alpha globin genes lead to alpha thalassemia major with hydros fetalis. The diagnosis of alpha thalassemia is by exclusion when there is decreased MCV without identifiable cause. Also, number of missing alpha gene by molecular technique and PCR. Thank you very much.